Private equity bought your doctor, and why your next bill will be $10,000. That MRI your neighbor got for $1,842? Same machine, same scan, same radiologist. Her bill came back $9,876 in 2024. Only difference, a new private equity owner. If your doctor's office changed names recently, your bill's about to change too. Here's the killer line item you never saw before. Facility fee. It's legal, and it's everywhere. During downturns, roll UPS accelerate, and this wave spreads fastest in recessions. In May 2024, the FTC launched a public inquiry into stealth consolidation, and in June 2020, the Senate Finance Committee released a 136-page report on youth treatment abuses. Proof this isn't niche. In the next few minutes, you'll learn the exact playbook private equity uses, why it lands on your bill, and how to spot and avoid the worst traps before your next appointment. Why now bridge, urgency plus stakes plus simple model. Healthcare costs climb faster than wages, and surprise bills bench even insured families. You do everything right, pick an in-network doctor, get pre-approved, and still get slammed. Why now? Because consolidation feeds on stress. When rates rise and margins thin, small practices sell. Private equity shows up with a check, debt, and a plan. Year 1 feels fine. Year 2, your copay hasn't changed, but the balance after insurance explodes. Regulators see it too. The FTC/DOJ/HS cross-government inquiry kicked off in March, May 2024 to examine these roll UPS, and 3 states, Indiana, New Mexico, and Massachusetts, passed new oversight laws in 2024. Let me give you a simple model. Think of clinics like rental properties. You buy a building with steady tenants, leverage it with a big mortgage, raise the rent, charge new fees for the parking lot and the elevator, and flip it a few years later to someone who pays more because the income looks higher. Translate that to medicine. Buy a platform practice, add smaller clinics, push higher codes, tack on facility charges, and grow revenue without adding better care. The flip is the point. Here's the clock you can't see. Insurer contracts reset on cycles, often annually. When ownership changes, the negotiating posture changes. A roll-up can briefly drop out of network to force higher rates, then return with a richer deal. Your employer plan absorbs it, then your premiums and deductibles move up. Medicare sets a floor, but commercial prices are where the spread lives. Meanwhile, turnover from clinician burnout costs nearly $1 billion a year in excess expenditures, pressure you eventually pay. What's the payoff today? A 3-part map. First, who's buying and why certain specialties get targeted first. Second, how they monetize, coding, site of service, and ancillary add-ons that multiply bills. Third, what you can do, questions to ask, traps to avoid, and alternatives that align with your wallet. If you've noticed your doctor's logo change to medical group, or bills arriving from companies you've never met, this is your early warning. Once you see the levers, you can steer around them. The lay of the land, how healthcare money flows today. Let's get the money map clear. 3 payer lanes dominate: employer-sponsored plans, government programs like Medicare and Medicaid, and individual plans on exchanges. Medicare and Medicaid publish fee schedules, so they set practical floors for many services. Commercial plans sit on top of that, negotiating rates clinic by clinic. Every owner in healthcare knows 2 profit levers matter most: price per procedure and volume per provider. Everything else is a tactic to move one of those levers. Here's the thing most people miss: the site of service differential. The exact same service, say an echocardiogram, can bill at wildly different rates depending on where it happens and who owns it. In a physician's office, you'll see a professional fee. Move that same test to a hospital outpatient department or a clinic allowed to use provider-based billing, and a second line appears: the facility fee. It's the administrative and overhead charge tied to the site, not the doctor's work. When independent clinics get absorbed into hospital systems or hospital-affiliated entities, that designation can flip on, and patients start seeing hundreds, or thousands, added to routine visits. You didn't get more care. You got a different setting. That's why site-neutral payment proposals keep surfacing. They would erase this game if widely adopted. Now layer on prior authorization and coding. Prior auth is pitched as utilization control, but practically, it's a friction gate. Owners that systematize it well can push higher value services through, and those that don't lose revenue. Coding is the language your visit is translated into. Evaluation and management levels go from simple to complex. The reason this matters is simple: higher levels pay more. In ERs, surgical centers, dermatology, and OB/GYN, you'll see protocols and templates that tilt documentation toward higher complexity. Sometimes that's justified, sometimes it's aggressive. Either way, coding moves price. Researchers have tied acquisition waves to increases in hospital-acquired conditions and staffing cuts in acute settings, signs of pressure leaking into outcomes. Ancillary services are the quiet multiplier. Pathology, imaging, anesthesia, lab work, each can be billed by separate entities. If the group that owns your clinic also owns the lab, it captures more of the bill. If it outsources to a sister company, the charges can stack. For you, that turns a straightforward procedure into multiple bills from unfamiliar companies, each with its own network status. One goes out of network for a quarter, you're holding the bag. Volume per provider is about throughput. Appointment slots get tighter, templates compress, and clinical staff absorb tasks once handled by non-billable roles. When a system focuses on relative value units, or RVUs, clinicians feel the clock. Shorter visits push more encounters per day, and a higher percentage of those encounters get routed to procedures with predictable codes. Preventive care, time-intensive and often lower margin, loses out to services that reimburse better. That's not a moral failing, it's an incentive map. Burnout follows, and physician turnover alone drives roughly $979 million a year in excess costs, with about $260 million linked directly to burnout. Now, connect these dots to ownership. When debt enters the picture, there's a minimum revenue target baked in. Interest has to be paid. Owners can't meaningfully change Medicare rates, so commercial contracts, coding intensity, site selection, and ancillaries become the control panel. Consolidation expands negotiating power with insurers. A single independent practice has to take what it's offered. A rolled-up group can threaten to leave the network across dozens of locations. Even a brief out-of-network period creates leverage. Some contracts resolve with higher allowed amounts. Those dollars don't appear on a brochure. They show up on your explanation of benefits. A quick story. A viewer emailed me last month after a routine colonoscopy. Same doctor as 2 years ago, same surgical center, but now the center had been reclassified under a hospital partner. The old bill was a single line for the procedure and an anesthesia charge. The new bill had an additional facility fee that doubled the out-of-pocket, plus a pathology bill from a lab with a different name that was briefly out of network. Total patient cost went from a few hundred to several thousand. Nothing about his colon changed. The ownership did. Common mistakes to avoid start here. Don't assume in-network doctor means in-network everything. Verify every entity touching your care: the facility, the lab, the anesthesiology group, the imaging center. Ask directly about site of service. Is there an office-based option? Get the CPT codes before you schedule and request a pre-quote. Independent imaging centers and ambulatory surgical centers often publish cash rates that beat insured rates applied to hospital-affiliated sites. If you remember nothing else, remember this: the setting drives the bill more than the service. Once you see these levers, price per procedure and volume per provider, amplified by site of service, coding, and ancillaries, the private equity playbook stops being mysterious. It's just financial engineering applied to clinical workflows. The next section walks through that playbook step by step so you can spot the early signs: the rebrand, the scheduling density, and the sudden arrival of separate bills. And then we'll get into exactly how to protect yourself without skipping necessary care. The PE playbook, step by step. Now that you see the levers, the playbook clicks. It starts with a platform. Investors hunt for a respected, profitable practice with clean operations and a recognizable brand. Dermatology group with strong cash pay. Regional anesthesia practice that staffs multiple hospitals. OB/GYN network with high delivery volume. The platform is the anchor. It has stable reimbursement, leaders willing to sell equity, and room to bolt on smaller clinics. This isn't random. Platforms sit in specialties with predictable coding, recurring demand, and clear ancillary revenue. In 2024 alone, researchers tracked 1,049 PE-backed healthcare deals, evidence that this platform and add-on model is running at scale. Once the platform is set, the roll-up begins. The team targets dozens of smaller practices nearby. Owners who are tired, under administrative strain, or worried about payer cuts. Add-ons join for upfront cash, back-end equity, and relief from management headaches. Central billing, purchasing, HR, and credentialing move to headquarters. Suddenly, 20 little islands become one continent. The power shift is immediate. Insurers can't ignore a group that controls a third of a market's dermatology slots, or half the anesthesia. Coverage in local hospitals. Here's where most people mess up. They assume consolidation is just about negotiation. It's also about protocols. After closing, the new owner standardizes documentation and coding. Templates steer to supported higher evaluation and management levels. Modifier usage tightens, and documentation checklists ensure each bill captures everything allowed. The reason this works is simple. Many small practices undercode to avoid denials. The new owner doesn't. They train, audit, and coach to maximize every visit's RVUs. Once you nail coding discipline, everything else clicks. Ancillary services. The platform expands what's billable in-house. Dermatology adds pathology labs and in-office excisions. GI builds an own pathology pipeline. Women's health layers ultrasound, fertility consults, and genetic screening. Radiology optimizes protocol mixes and throughput. Each add-on captures revenue that previously leaked to unrelated vendors. If you remember nothing else here, remember that ancillaries multiply dollars per patient without adding new patients. The game changer nobody talks about is site of service. If any location can be designated as provider-based or tied to a hospital outpatient department, a facility fee appears. That single status change converts one line into two, with the technical component divorced from the physician's work. Owners map which services move profitably to those sites. Infusions, imaging, procedures that don't require inpatient care. They keep the easy, low-margin stuff in the office and migrate lucrative services to facility fee-eligible settings. The patient experience looks the same, the bill doesn't. Scheduling density follows. Open slots are money left on the table. Templates compress from 20 to 15 minutes. Nurse practitioners or physician assistants handle routine follow-ups, freeing physicians for procedures. Same-day add-ons fill gaps. No-show rates get algorithmic nudges, confirmations, waitlists overbooking. Throughput rises, RVUs per clinician jump, and the revenue line responds. The tricky part is avoiding burnout. Some groups reinvest in scribes or better EHR tools. Others just push harder. You'll feel the difference at the front desk and in rushed visits. Before we continue, you need to understand the debt layer. Deals are financed with leverage. That means every month, interest and principal payments must be covered before equity sees a dime. Debt is a metronome that sets the minimum beat. When reimbursement dips or volume softens, the pressure transfers to coding intensity, site shifts, and cost cuts. Labor becomes the biggest variable cost, so staffing ratios change. Non-billable roles, care coordinators, phone triage, nurse education get trimmed. The spreadsheet shows savings, the waiting room shows strain. This is also where legal risk creeps in. Since 2014, PE-linked healthcare firms have paid over $500 million to settle False Claims Act cases. Proof that aggressive revenue tactics sometimes cross lines. Negotiating with insurers gets more aggressive. A larger group threatens to go out of network to force rate increases. Temporary contract breaks are used as leverage, then rates reset higher when the contract returns. Even if you're still in network, allowed amounts creep up. Employers with self-funded plans absorb the difference and pass it back through premiums and deductibles. The optics are clean, no giant headlines, but your paycheck notices. Now the flip. Most funds target a 3 to 5 year exit. The thesis is multiple expansion. Buy smaller clinics at, say, 6 times earnings, integrate them, demonstrate higher revenue per visit and better payer rates, then sell the bigger machine at 8 to 10 times. Sometimes there's a recapitalization midstream, where the company borrows more to pay a dividend to owners. The spreadsheet loves it. The balance sheet gets heavier. Patients don't get a say. What changes for you the day after a deal? More separate bills from affiliated entities, new logos, tighter scheduling, and different sites of service for procedures. You'll hear standardized care pathways, which can be good when they reduce variation and harmful when they overfit to revenue. Out-of-network surprises pop up during contract standoffs. And you'll feel the tempo, faster visits, more checklists, fewer long conversations. The thing most people miss is that none of this requires fraud. It's about exhausting every legal revenue lever. That's why your MRI jumped from $1,842 to $9,876 without better care. Ownership changed the setting, the code, and the contract. Coming up, we'll break down where the shock charges hide, line by line, so you can spot them before they hit your mailbox. Where your bill explodes, the 4 hidden charges. Let's pull the curtain back on the 4-line items that quietly turn a routine visit into a 4-figure bill. I'll show you what each looks like on paper, why it appears after an acquisition, and exactly how to avoid the worst of it. Regulators are focused here too. The No Surprises Act curbs some shocks, but arbitration backlogs let contract standoffs linger, and provider-based billing keeps 2-line outpatient bills alive until site-neutral rules expand. First, facility fees. This is the big one. When a clinic is reclassified as a hospital outpatient department or provider-based, your bill splits into 2, the professional fee for the clinician and a separate technical or facility fee for the site. Same room, same nurse, same ultrasound. Now there's a second charge for the building's overhead. After role UPS or hospital affiliations, this switch flips fast because it's legal and lucrative. The reason this matters is simple. That extra line can add hundreds or thousands to common services like infusions, imaging, or minor procedures. How do you blunt it? Before scheduling, ask, is this billed as hospital outpatient or office-based? If it's hospital outpatient, ask for the office option or an independent center. Many independent imaging centers list cash rates lower than your insured price at a facility fee site. Now here's where most people get caught, out-of-network traps. During contract renegotiations, groups sometimes go out of network for weeks or months to pressure insurers. You still see the same doctor in the same building, but your explanation of benefits shows out-of-network provider, and the allowed amount plunges while your share spikes. It's even sneakier with separate entities. The clinic is in-network, but anesthesia, pathology, or imaging isn't. That's how surprise bills used to erupt, and even with protections, timing gaps and carve-outs still bite. Your defense is boring but powerful. Verify every entity touching your care. Call and ask, is the facility in-network? Is the anesthesiology group in-network? Which lab processes my specimen, and is it in-network? If they can't answer, ask for the billing entity names and confirm with your plan. Third, ancillary add-ons. Think pathology, imaging, anesthesia, durable medical equipment. Each can be billed by a separate company the roll-up owns or partners with. The business logic is to capture revenue leakage. For you, that turns 1 visit into 4 bills. A dermatology excision suddenly includes a pathology bill routed to an affiliated lab. A GI procedure adds a pathology panel you didn't discuss. A routine OB visit includes an outsourced ultrasound read. The thing most people miss is that these charges can be medically reasonable, yet still avoidable or optimizable. Ask for the CPT codes for planned ancillaries and whether they're bundled or separate. Clarify, will pathology be sent to an in-network lab? If not, can you route to one? And if it's elective timing, shop independent centers that give all-in quotes. Finally, evaluation and management upcoding. Same visit length, different code. After consolidation, documentation templates push to higher complexity levels when criteria are met. Again, that can be legitimate. Complex histories and decision-making should pay more. But aggressive defaults turn routine visits into level UPS that increase your coinsurance. The shortcut nobody teaches. Compare this year's E&M level to your last similar visit. If it jumped without a clear change in complexity, request an itemized bill and the visit note summary. You can file a polite appeal asking the provider to re-review the code, especially if the documented elements don't support the level billed. Many practices will adjust once you ask for medical necessity documentation. Let me give you a quick microstory. A subscriber had a knee MRI quoted at an in-network hospital outpatient center. The estimate didn't include the facility fee. The final bill did, plus a radiology professional fee from an out-of-network reading group. Total out-of-pocket, triple the independent center across town. He called back, asked for CPT 73721 at an office-based site, and got a cash quote under his deductible. Same machine manufacturer, different billing entities, thousands saved. Common mistakes to avoid: assuming pre-authorization equals price certainty, trusting a single in-network confirmation, and skipping CPT codes. Your 3-question checklist before care. 1. What's the site of service and will there be a facility or technical fee? 2. List every billing entity involved, clinic, facility, anesthesia, radiology lab, and confirm each is in network. 3. Please give me the CPT codes so I can verify coverage and compare totals. If the scheduler can't help, ask for billing or the pre-cert team. If you remember nothing else, remember this: the ugliest charges don't come from the doctor's hands. They come from the setting, the network status, and the add-ons. Get those 3 right, and your bill shrinks before anyone touches a scalpel. What happens to care? Time, staffing, outcomes. So what does all this financial engineering feel like in the exam room? Start with time. When RVUs drive the day, appointment slots tighten. 15 minutes becomes 12, then 10. Clinicians start pre-charting at 6 a.m. and finishing notes at 9 p.m. The tricky part is that less face time often means less context, fewer follow-up questions, fewer clarifications, and more "let's order a test to be safe," which can spiral into more billing and still miss the underlying issue. Continuity takes the hit. When your primary leaves or is only available midweek, you end up repeating your story to whoever's on the schedule. Burnout rises. Turnover costs alone approach $979 million annually, and quality follows time out the door. Now staffing. Non-billable roles are first on the chopping block because spreadsheets love salary lines. Care coordinators, triage nurses, medical assistants extra per doctor, even front desk floaters. Those positions smooth care but don't generate direct revenue. Cut them, and the work doesn't vanish. It slides onto clinicians. You'll notice phones ringing longer, portals unanswered, refills delayed, and prior auth ping-pong landing back in your lap. In emergency departments and ICUs after private equity acquisitions, researchers documented double-digit cuts in staffing expenditures and a corresponding rise in ED mortality. That's not a scare line. When ratios stretch, seconds matter. The thing most people miss is how staffing mix changes decision-making. Substituting experienced nurses with less expensive staff reduces the catch rate on subtle deterioration. Replacing physicians with less supervised mid-level coverage in high-acuity settings can push error rates up. On paper, coverage looks the same. On the floor, escalation lags a little more often, and complications creep. In clinics, fewer nurses means more inbox messages routed to templates and fewer callbacks that solve problems before they become visits. Care priorities shift too. Preventive care is time-heavy and margin-light. High-margin procedures and diagnostics are the opposite. Under pressure, the schedule tilts. You'll see more slots for procedures, fewer for complex conversation visits. Dermatology steers toward excisions and cosmetic add-ons. GI optimizes procedural days. Women's health expands ultrasound and genetic testing blocks. Some of that improves access. Some just chases revenue. The risk is overuse on the profitable side and underinvestment, where prevention pays off later. Let me show you how that lands for a patient. A viewer with diabetes used to have 30-minute follow-ups with a nurse educator embedded in primary care. After an acquisition, those educators were laid off. Visits dropped to 15 minutes with the physician, and education shifted to a printed handout and a web link. Months later, she ended up in the ER with hypoglycemia related to medication timing, something her old educator would have caught. The ER visit billed thousands. The canceled educator role saved tens of thousands across the system. That's the wrong ledger. Studies have linked post-acquisition staffing cuts in EDs and ICUs to higher mortality. Seconds matter when ratios stretch. Burnout isn't just a clinician problem, it loops back to outcomes. When autonomy erodes and quotas rise, error rates go up, turnover accelerates, and continuity breaks. Every time a primary or specialist leaves, you restart the relationship, re-explain your history, and rerun tests because records aren't seamlessly reconciled. There's real cost here. Research pegs primary care turnover at nearly $1 billion annually in excess expenditures, with a sizable chunk tied to burnout. For you, that's fragmented care and higher bills. For clinicians, it's moral distress. Okay, so how do you navigate this without skipping necessary care? Use the system's own choke points to your advantage. Ask for longer slots when complexity warrants it. I have 3 issues. Can we book a comprehensive visit? Document in your portal what you need ahead of time so your doctor can prep. If the office offloaded education, request a referral to a certified educator or a covered program. Many plans include them. 4 time-sensitive needs. Use your plan's nurse line to triage. Well-run lines can bypass clogged front desks. Now here's where most people mess up. Assuming the fastest available provider is always the right fit. 4 straightforward follow-ups. A nurse practitioner with good support can be great. For diagnostic uncertainty or high-acuity decisions, ask specifically for physician review or a team visit. Clarify how supervision works. You're not being difficult, you're matching the skill to the task. Finally, a quick checkpoint. If you start seeing rushed visits, staff turnover, and more procedures pushed without clear benefit, that's a signal to slow down and ask why. What changes if we wait? Is there an office-based alternative? Can we try conservative care first? The reason this works is it forces a clinical rationale over a revenue pathway. Once you hear a coherent plan tied to your outcomes, proceed. If you get vague answers and persistent upsell, consider a second opinion, ideally from an independent clinic. Follow the debt. Why 20% returns demand 20% pain. Let's talk about the engine under the hood, leverage. When a fund buys a practice, it doesn't pay cash. It layers debt onto the company, sometimes multiple turns of EBITDA. So every month there's a fixed nut to cover before anyone gets paid. Debt service behaves like gravity. If volume dips or payer mix worsens, something else must rise. Prices, coding intensity, site of service shifts, or cost cuts. That's why you feel pressure, even when nothing about your diagnosis changed. In 2024, regulators labeled serial acquisitions a stealth consolidation scheme. Debt and deal speed are the fuel. Here's the simple math. If investors target a 20% internal rate of return over 3 to 5 years, they need cash flows that climb fast. Debt amplifies returns on the upside, but it also narrows the path. Miss budget, and the lender starts calling. Hit budget, and you're rewarded to push harder next quarter. The metronome never stops. Therefore, leadership leans on levers that move today, not the ones that pay off in 3 years, like prevention or staffing resilience. Multiple expansion is the second half of the story. You buy smaller clinics at a lower multiple, stitch them together, increase average revenue per visit via coding and facilities, show payer contracts that price higher, and then sell the bigger platform at a richer multiple. The spreadsheet calls it value creation. Clinically, it often shows up as procedural tilt, add-on services, and short visits that generate more RVUs per hour. It doesn't require fraud, it rewards intensity. Now here's where most people mess up, assuming cost-cutting lives only in office supplies. Labor is the largest cost. Non-billable roles are exposed first, and staffing mix moves next. Fewer experienced nurses per physician, more mid-level coverage, fewer dedicated educators. You can run lean without breaking care, but debt tightens the margin for error. In acute settings, shaving minutes of coverage or stretching ratios can push events from near miss to harm. On paper, the savings look clean. At the bedside, delays compound. Covenants are the tripwire. Loan agreements include tests, leverage ratios, interest coverage, minimum EBITDA. When interest rates rise or reimbursement softens, those tests get harder. If the company drifts close to a breach, leadership scrambles. Freeze hiring, slow payments to vendors, delay equipment, accelerate collections, and squeeze scheduling. Corners get sanded. Temporary measures linger because the next quarter arrives fast. That's why downturns accelerate consolidation. The stressed seller has fewer options, and buyers can dictate tougher terms. Dividend recapitalizations add another gear. Mid-hold, the company borrows more and pays a dividend to owners. Equity de-risks, but operating cash now supports a larger debt load. The practice feels it as stricter productivity targets, stricter denials management, and less tolerance for long visits. You won't see dividend on your bill. You'll feel it in rushed care and expanded facility fee footprints. Case in point. In September 2024, Help at Home paid a $262.6 million debt-funded dividend to its PE owners months after shuttering operations in Alabama, while expanding in other non-Medicaid expansion states. That's the incentive map in plain view. So where is the line between efficiency and danger? Efficiency removes waste that doesn't alter outcomes. Bulk purchasing, centralized billing done well, tech that frees clinician time, better referral routing. Danger starts when throughput targets ignore clinical complexity, when supervision thins in high-acuity settings, and when site shifts chase fees over safety. If you remember nothing else here, remember this. Debt prefers predictable revenue. Human illness is not predictable. The tension is fundamental. Let me show you how this plays out in real decisions. A practice faces a softer quarter, flu surge passes, referrals slow. The model still expects revenue growth. Leaders consider 3 moves: push visit levels up through stricter documentation templates, migrate a slate of infusions from the office to a hospital-affiliated site to capture technical fees, and trim after-hours triage to cut costs. All 3 help the month's numbers. 2 increase your out-of-pocket. 1 increases the chance you end up in the ER. The spreadsheet can't see that last part. What can you do with this knowledge? First, time your elective care. Ask scheduling to place you after contract renewals settle, not during negotiations that risk out-of-network traps. Second, prefer settings where prices are site-neutral or transparent. Independent imaging, ambulatory surgery centers that quote all in bundles. Third, push for clarity when a service is moved. Why did this shift sites? What's the clinical benefit? If the only answer is standard process, ask for the office-based alternative in writing. Now, to be fair, leverage isn't always destructive. Some groups use it to invest in equipment, extend hours, add scribes, and build better triage, all of which can improve outcomes and access. The difference is whether the debt is sized to the clinical reality or the pro forma fantasy. You can usually tell by how they respond to reasonable safety requests. If the answer to every concern is productivity, the balance sheet is driving care. The takeaway is simple: 20% returns don't appear by magic. They're extracted. If the payer mix can't absorb it, if employers resist rate hikes, the pressure moves inside the clinic, toward your bill, your visit length, and your care setting. Knowing that, you can ask sharper questions, choose safer sites, and escalate when financial policies start to override clinical sense. Once you see the debt clock, you can hear it in every policy memo, and you'll know when to step around it. The hot zones, Specialties PE targets first. Once you hear the debt clock, the specialty map snaps into focus. Some fields print reliable RVUs, some have captive demand, and some let owners stack ancillaries. That's where private equity goes first. Dental care is the canary. 161 PE dental deals in 2024, with specialists like endodontists and oral surgeons consolidating fastest. Dermatology and aesthetics are the classic entry point. Why? Predictable procedures, a mix of insurance and cash pay, and pathology you can pull in-house. The thing most people miss is how diversified the revenue is here. Medical dermatology feeds biopsies to an owned lab. Surgical derm adds excisions and Mohs. Cosmetics bring cash that clears in seconds with no insurer arguing medical necessity. After a roll-up, you'll notice more same-day biopsies, tighter recall cycles, and a menu of cosmetic upsells. On paper, it's efficient. On your bill, the pathology line shows up from an affiliate you've never met. Ask early where specimens go and whether that lab is in-network. Emergency medicine and urgent care sit at the other extreme, captive demand. When you're in crisis, you don't shop. That's fertile ground for aggressive coding and contract brinkmanship. Large staffing companies, including PE-backed ones, now cover a big chunk of ED shifts, and hospital acquisitions tied to aggressive cost cuts have been linked with staffing reductions and higher ED mortality. In some analyses, ED deaths rose after acquisitions, while salary spend dropped double digits. In urgent care, the pattern is volume, templates that push higher visit levels when justified, and imaging on site to capture add-ons. Your defense is simple, not easy. Confirm network status for the facility and the clinician group, especially during contract renewals, and ask about cash rates at urgent care before you default to the ED for non-emergencies. Anesthesiology, radiology, and pathology are the invisible specialties because they bill separately and patients usually don't choose them. That opacity invites consolidation. Owners can negotiate hard with payers and hospitals, then recover revenue through coding intensity and add-on interpretations. You feel this as surprise bills when the facility is in-network, but the reading group isn't, or as multiple technical and professional components attached to a single episode. The shortcut nobody teaches. Before a procedure, ask your surgeon's office to list the anesthesiology and radiology entities and confirm they're in-network. If not, request alternatives. Dentistry, orthodontics, and vision are fragmented and ripe for playbooks that harvest arbitrage. Dental roll-ups chase geographic density, centralized scheduling, and shift mix from preventive to restorative and specialty work. Studies have documented charge increases without higher allowed prices, plus a tilt toward higher cost procedures. That doesn't mean every recommendation is wrong. It means incentives lean toward intervention. You can counter by asking for treatment plans that include preventive alternatives, requesting radiograph copies to seek a second opinion, and checking cash bundle quotes at independent clinics. Women's health and fertility combine recurring visits with high willingness to pay. OB/GYN offers ultrasound, genetic screening, and lab panels. Fertility stacks consults, monitoring, procedures, pharmacy, and lab into a multi-bill arc. After consolidation, you'll see standardized pathways, more bundled packages, and frequent use of outside labs. The risk is financial, not just clinical. A single out-of-network lab in that chain can detonate your budget. Ask for a written list of all billing entities for the cycle and confirm each one before you start. Gastroenterology, orthopedics, and ophthalmology also rank high. GI is procedure-rich, endoscopy days, pathology on every polyp, infusion suites for IBD. Ortho packs imaging, injections, ambulatory surgeries, and durable medical equipment. Ophthalmology offers cataracts, retina injections, and cash pay refractive services. In each, the playbook is the same. Optimize throughput, bring ancillaries in-house, and shift high-revenue services to sites that can charge facility fees. Your move is to separate clinical need from site economics. Is there an office-based option? Can pathology go to my plan's preferred lab? What's the all-in price at the ambulatory surgery center versus hospital outpatient? Behavioral health and post-acute sectors, home health, hospice, and nursing homes attract investors because of recurring revenue and growing demand. But when staffing is the product, cost cuts hit fast. You'll feel it as shorter visits, turnover, and harder to reach clinicians. Press for continuity. Ask how coverage works after hours, how many patients each clinician manages, and whether you'll keep the same therapist or nurse. Here's the pattern to remember. PE targets specialties with at least 2 of 3 traits: predictable volume, billable ancillaries, and weak patient shopping power. Dermatology, emergency medicine, anesthesia, radiology, pathology, dentistry, women's health, GI, ortho, and vision check those boxes in different ways. That doesn't make every group bad. It explains why you're seeing rebrands there first. A quick micro-story. A viewer scheduled a cataract at a hospital outpatient department because that's where we do them. He asked for a cash quote at an ambulatory surgery center across town. Same surgeon, different site of service. The ASC quoted a bundled price under his deductible. The hospital version included a facility fee that tripled the out-of-pocket. One question changed the setting and saved thousands. Once you can spot these hot zones, you can predict the billing moves before they hit. Coming up, we'll look at how insurers push back, how the standoff sets your prices, and the one loophole that keeps facility fees flowing. Insurers versus PE, the negotiation that sets your prices. Now that you can spot the hot zones, let's talk about the cage match that actually sets your bill: contracts between insurers and provider groups. This isn't abstract. Every CPT code has an allowed amount that comes from these negotiations. Change who sits at the table, and the number moves. In January 2025, HHS, DOJ, and the FTC published a joint report calling for more ownership transparency and lower reporting thresholds for deals, because these contract dynamics are reshaping local prices. Here's the dynamic. Insurers want broad networks and predictable costs. Private equity-backed groups want higher rates and faster payment. When a roll-up controls enough doctors or hospital coverage in a region, it has leverage. Pay more or lose access. That's why consolidation matters. One practice walking away is a headline. 50 practices walking away is a crisis for an insurer's network adequacy. Contract brinkmanship is the move. A PE-owned group will signal non-renewal months before a deadline, then let the deal lapse. For a few weeks or months, they're out of network. Patients get letters that their doctor is no longer participating. Phones melt. Employers panic. Insurers face member complaints. The group uses that pressure to lift rates, then returns in network with richer terms. You may never see the new numbers. You'll feel them in higher allowed amounts. Wait, doesn't the No Surprises Act protect you? It blocks many out-of-network shock bills in emergency and certain facility settings and routes price fights into arbitration. That reduced the most egregious ER and anesthesia surprises. But it didn't solve everything. Office-based clinics, labs, and some ancillaries can still generate pain when they're out of network. And even when surprise billing is curbed, the negotiation simply moves upstream. Higher contracted rates instead of post-visit balance bills. Provider-based billing sits in the middle. Hospital systems and affiliated clinics can legally add facility fees to outpatient services. Insurers hate paying two lines for one visit, but if a hospital-backed network is dominant in a market, it's hard to refuse. That's why you keep hearing about site-neutral payment proposals, equal pay for the same service regardless of location. Until site-neutral rules expand, insurers often pay the facility fee and move the cost to employers and members through premiums and deductibles. Narrow networks are insurers' counterpunch. They steer members to lower-cost providers and exclude groups that demand top-dollar rates. That can work. Prices drop when volume is directed. But when a PE-backed group controls essential coverage, emergency staffing, anesthesiology at key hospitals, or a dominant specialty, building a narrow network without them risks network adequacy violations or member backlash. The result is a stalemate that ends with higher prices. Here's the part that hits your paycheck even if you never see the contract: self-funded employer plans. Most large employers don't buy insurance. They pay claims directly and rent the insurers. Network. When a contract resets at higher rates, employers absorb it. Next renewal, they increase employee premiums, deductibles, and co-insurance, or tighten benefits. The bill you see at the counter is only the visible slice. The rest shows up in smaller raises and bigger paycheck deductions. Arbitration is the new battlefield. The law set up an independent dispute resolution process for certain out-of-network claims. Backlogs and procedural tug-of-war mean months of uncertainty. Some provider groups lean on arbitration outcomes to anchor higher in-network rates. Some insurers push for downbeat benchmarks. You won't be in the room, but delays can keep groups briefly out of network, again leverage. So what do you do with all this? 3 moves. First, time elective care outside of known renegotiation windows. Offices will often hint, "Our contract is pending." Ask directly whether they anticipate network changes in the next 60 days. Second, always verify both the facility and the physician group network status before procedures. Same building, different contracts. Third, ask if there's a site-neutral or office-based option that your plan favors. Many insurers now publish preferred sites for imaging and outpatient procedures with lower copays. Use those lists. One more loophole to watch: carve-outs. Insurers sometimes carve out radiology reads, lab processing, or anesthesia to third parties. Your surgeon and facility may be in-network, but the carved-out entity isn't. Ask for the billing entity names for every component and cross-check with your plan's directory or concierge line. Until site-neutral payments and serial acquisition oversight expand, carve-outs and provider-based billing keep costs elevated even when you think you've checked the in-network box. The pattern to remember is simple. PE-backed groups gain negotiating power via consolidation and use temporary out-of-network periods and provider-based billing to lift allowed amounts. Insurers counter with narrow networks, arbitration, and steerage. Employers sit in the middle and pass costs to workers. You can't rewrite those contracts, but you can pick settings, confirm entities, and schedule around the crossfire. The fewer facility fees and carve-outs you invite, the less those negotiations leak into your life. What the law tried to fix, and what it missed. You've seen how contracts set prices, and why consolidation tilts the table. Now let's talk about the rules that were supposed to protect you, and where they fall short. In 2024, the FTC and DOJ opened a public inquiry into serial acquisitions, and HHS joined a cross-government request for information focused on healthcare ownership and transactions. The Senate Finance Committee issued a 136-page report on youth residential treatment failings. State legislatures in Indiana, New Mexico, and Massachusetts moved to tighten oversight. The system knows there's a problem. Fixes are partial and slow. Start with the No Surprises Act. It shut down many of the worst surprise bills and emergencies, and when you're treated at in-network facilities. Instead of sticking you with the difference, disputes go to arbitration. That's good, but the law is narrow. Office-based care isn't fully covered. Some ancillaries still slip through, and the process itself has been jammed with backlogs. When arbitration drags for months, groups can hover out of network and use the uncertainty as leverage in parallel negotiations. You're protected from a giant post-visit balance, but you're not protected from higher in-network rates that get baked in later. Next, site-neutral payments, the cleanest fix that hasn't happened. The principle is simple. Pay the same price for the same service, whether it's in a hospital outpatient department or an office. If implemented broadly, the facility fee game fades. Policymakers have floated proposals and made limited moves, but the big change hasn't landed nationwide. Hospital systems argue their overhead justifies higher outpatient rates. Insurers and employers argue patients shouldn't subsidize identical care because of a logo. Until site-neutral rules expand, provider-based billing stays legal, and your two-line bill persists. Antitrust is the other big lever, but there's a catch. Most physician practice deals are small. Individually, they don't trigger mandatory reporting. Collectively, they reshape local markets. Regulators call this serial acquisitions. The Federal Trade Commission has signaled interest in these roll-up patterns, and researchers have documented rising concentration in specialties like anesthesia and emergency medicine. The problem is speed and scope. By the time an investigation maps the network, dozens of add-on deals are done. Blocking a merger is easier than unwinding a quilt. There's also the corporate practice of medicine and fee-splitting laws. On paper, these rules protect physician autonomy and bar non-physicians from controlling medical decisions. In practice, management services agreements let investors run the business side, staffing, scheduling, revenue cycle, while a physician-owned shell holds the clinical keys. When things go wrong, enforcement can bite through fraud or false claims cases, and there have been settlements where owners paid up. But day to day, most pressure happens inside the lines. Productivity targets, coding standards, and site shifts that are legal yet misaligned with your wallet. Surprise billing protections did push behavior. With balance bills harder to collect, some groups emphasize front-end contracting power. Temporary, out-of-network standoffs increase. Narrow networks expand. Arbitration outcomes inform future in-network rates. In other words, the fight moved from your mailbox to the negotiating table, and costs migrate into premiums and deductibles. You still pay, just not as a single shocking invoice. State-level patches add complexity. Some states cap facility fees in off-campus sites, require disclosure of provider-based status, or demand upfront estimates. Others have certificate of need rules that control where services can open, which can slow both abuse and competition. It's a patchwork. If you cross a state line, protections change. Even within a state, hospital affiliations can flip billing status overnight after a quiet rebrand. That's why transparency requirements, posting negotiated rates and machine-readable price files, matter, even if they're clunky today. They give employers and savvy patients ammunition to steer. And when clinicians work in systems that reward prevention, not just throughput, you see it. Fewer duplicate tests, better coordination, and fewer facility fee detours. What about quality enforcement? Agencies track hospital-acquired conditions, readmissions, and star ratings. There's emerging research linking staffing cuts after certain acquisitions to worse outcomes, especially in emergency departments. But for clinics, metrics are thinner and lagged. By the time a trend appears in public data, ownership may have changed again. Quality oversight moves slower than private deals. So, what did the law get right? It curbed the most egregious surprise bills and created a forum to settle out-of-network fights without bankrupting patients. Where is it weak? It didn't neutralize site-of-service pricing, didn't close the serial acquisition gap, and didn't stop legal revenue tactics that swell allowed amounts. It also can't restore time to your visit or staff to your clinic. Here's what helps tomorrow. Use disclosure rules. Ask if a clinic is provider-based, request good faith estimates, and check posted insurer-preferred sites for imaging and procedures. Push for site-neutral options in writing. If a group is in a contract standoff, reschedule elective care or choose independent centers with published bundles. When you see billing that doesn't match documentation, appeal. Laws around itemization and medical necessity are on your side. Laws move slowly. Incentives move fast. Until the big fixes land, your best defense is picking settings that blunt facility fees, confirming every billing entity, and timing care outside renegotiation storms. That's how you turn policy gaps into practical savings. Spotting a roll-up in your backyard. Let's make this practical. How do you spot a roll-up before it hits your bill? Start with the front door, names and logos. If your longtime clinic suddenly rebrands to Regional Medical Group, Physician Partners, or tax on health system affiliated, that's a strong tell. Look for tiny fine print on paperwork or door decals. Managed by Management Services Organization or Provider-Based Department of Hospital. Those phrases often signal ownership or billing status shifts. If your town's dental, dermatology, women's health, or GI clinics change logos in clusters, assume a platform is stitching together add-ons. Next, your mailbox. One visit turns into multiple envelopes. You used to get a single statement from your doctor. Now you're seeing separate bills for the clinic, a facility or technical charge, a lab pathology read, and maybe an imaging interpretation from a company you've never met. Even weirder, the return addresses are out of state. That's not random. Many roll-ups centralize billing and route ancillaries to affiliates. If the company names are new to you, flag it. On the phone, scheduling feels different. Hold times stretch. You're offered the next available with a provider you don't recognize. Your doctor, who used to be there 5 days a week, is now only on Wednesdays, and the rest are covered by rotating clinicians. That's provider churn, a classic side effect of consolidation and tighter productivity targets. If the portal suddenly pushes virtual follow-up for issues that used to be in person, or prompts add-ons you didn't request, the templates have changed. Inside the visit, count the upsells. Let's add an ultrasound today. We'll send this to our preferred lab. We recommend the extended panel. Some of that is clinically sound. The pattern to watch is frequency without clear rationale. If every visit layers ancillaries, or if you're steered to a different building for routine tests, the site of service chessboard is being played. Ask, is this office-based or hospital outpatient? And which lab reads this, and are they in-network? Your explanation of benefits tells stories too. Scan for facility or technical fees attached to outpatient visits that never used to have them. Look for provider-based department language. Note sudden jumps in allowed amounts for the same CPT codes compared to last year. If the allowed amount rose sharply with the same service, a contract likely reset under new ownership. Digital breadcrumbs matter. Check the practice website footer. A portfolio company of, or backed by, can appear after a deal. LinkedIn updates reveal leadership changes to Chief Revenue Cycle Officer, or Market Integration Lead. Job postings that emphasize coding optimization, RVU targets, or provider-based billing experience confirm priorities. None of these are smoking guns alone, but together they paint the roll-up picture. Pharmacy and referrals shift, too. If you're suddenly steered to a particular specialty center, imaging site, or infusion suite owned by the same group, that's vertical integration. It can be convenient, but it can also move you into facility fee zones or out-of-network ancillaries. Ask for choices. List 2 independent options and 2 affiliated ones, please. Insurance signals help. Your Insurers app may flag preferred centers for imaging or surgery with lower copays. If your clinic drops off that list after a rebrand, contracts changed. During renewal seasons, insurers send network change notices. If you get one naming your group, reschedule elective care until it's resolved or choose an independent site. Talk to staff kindly. Front desk teams know when ownership changes. Ask, has your billing process changed? Are procedures moving to different sites now? Which labs and anesthesia groups are you using? You're not interrogating, you're mapping the entities that'll appear on your bill. Here's a quick checklist to confirm a roll-up is in motion. New brand or medical group, name plus an MSO mention multiple separate bills for one episode of care facility / technical fees on routine outpatient visits, provider churn or reduced physician availability, scheduling density increases, and more add-on services, out-of-state billing addresses, and centralized portal steerage to affiliated labs, imaging, or surgery centers. Insurer notices about pending or changed network status if 3 or more show up. Assume incentives shifted. Don't panic, adjust. Before your next visit, call and ask, is this provider-based or office-based? List every billing entity, facility, lab, anesthesia, radiology, and confirm in-network. Can I do this at an independent site? If answers are vague, escalate to billing or your insurer's concierge. The goal isn't to fight care, it's to fight avoidable charges. Once you see the roll-up, you can route around its most expensive paths. Defensive playbook, cutting your exposure. Without skipping care. Let's turn the levers to your advantage. Start with the most powerful question you can ask before anything is scheduled. What's the site of service? If the answer is hospital, outpatient, or provider-based, ask, is there an office-based option? Make it concrete. Please quote me both ways. Follow with, will there be a facility or technical fee? If yes, ask for a CPT-coded estimate. This single move reroutes a big chunk of your costs. Remember, laws trim the worst balance bills, but not the higher allowed amounts that get baked into contracts. You avoid those with setting and timing. Next, verify network status for every entity, not just the clinic. Say, list all billing entities for this visit. Facility, clinician group, anesthesia, radiology, pathology lab. Then call your plan or use the portal to confirm each one. If anything is out of network, ask the clinic to use an in-network alternative. For labs, you can often pre-select your insurer's preferred partner. If they resist, ask for the physician's order so you can route it yourself. Now get CPT codes. Tell scheduling, I'm confirming coverage and comparing options. Please provide the CPT codes for all planned services. With codes, you can do 3 things fast. Check coverage rules, get prior estimates from your plan, and compare independent centers. Many imaging and ASC sites post cash bundles that beat insured rates at facility fee locations, especially under a deductible. For price clarity, request a good faith estimate in writing. Use this phrasing. Please provide an itemized good faith estimate including professional and facility components and the names of any third-party billers. If the final charges wildly exceed the estimate without added services, you have stronger footing to dispute. On surgery or procedures, ask for a bundled alternative. Can we schedule at an ambulatory surgery center with an all-in price? Compare the ASC's global fee to the hospital outpatient path. If your plan has preferred centers of excellence, use them. Employers often waive deductibles or offer travel stipends for those bundles. That's real money. During contract standoffs, time elective care. Ask, are you in any active payer renegotiations? If yes, move non-urgent services 30 to 60 days out or choose independent sites that aren't in the crossfire. Your goal isn't delay. It's avoiding brief out-of-network windows used as leverage. When you get the bill, slow down. Request an itemized statement and the visit documentation summary. Compare the E&M level to prior similar visits. If it jumped without clear complexity, ask the billing office to re-review the code. Be specific. Based on the note, I don't see the elements supporting a level 4. Would you consider adjusting to level 3? Keep it polite and factual. Appeal denials or questionable adds with a tight script. State the CPT, date of service, and reason for appeal. Attach the estimate or pre-authorization reference. If a service was moved to a higher-cost site without clinical justification, say so and request repricing to the office rate. If an ancillary was out of network without disclosure, request in-network adjudication under your plan's policies. If you're overwhelmed, use plan resources. Many employer plans have patient advocates, navigation hotlines, or second opinion programs. Ask HR if there's steerage to preferred centers, cash bundle options, or a concierge that can confirm all entities before you book. These teams can also negotiate one-time case rates for you. For imaging, always shop. With CPT codes in hand, call 2 independent centers and your plan's preferred vendor list. Ask 3 questions. All in price. Radiologist group in network? How are repeats handled if quality is insufficient? Choose the one that answers cleanly and puts the quote in writing. For lab work, bring your insurer's preferred lab order form. Tell the office, please route to this lab. It's required for my coverage. If they insist on their affiliate, ask for a paper order and take it yourself to the preferred site. You're not refusing care, you're directing the specimen. On medications and infusions, ask about site of care shifts. Can this infusion be done in office or at a home infusion provider that's in network? Many plans have site of care programs that move drugs out of hospital outpatient departments to dramatically cheaper settings with nurse oversight. If you face a facility fee for routine visits, ask for a non-provider-based location or telehealth alternative. For follow-ups that don't need procedures or equipment, telehealth can avoid technical fees altogether when allowed by your plan. Use your deductible strategically. If you need multiple services, cluster them in the same plan year after you've met your deductible. But don't chase deductible spend at high-cost sites. Meet it with independent centers or bundles where possible. The remainder of the year then runs. Cheaper everywhere. Build a personal care map. Keep a note with your preferred independent imaging center, ASC, lab, and urgent care, all confirmed in network. Share it with your primary and specialists. Please route here unless there's a clinical reason not to. Most teams will accommodate if you hand them specifics. For complex care, ask for a decision rationale. What's the clinical benefit of doing this at the hospital site? If the answer is equipment or staffing, fair. If it's standard process, ask again. Is there a clinically appropriate office-based alternative? Please note that in my chart, that paper trail helps later. Last, practice 2 phrases that save money. I'd like the office-based option, and please route all labs and reads to in-network providers. Use them early, at scheduling, pre-op calls, and check-in. You're not gaming the system. You're choosing the pathway that pays for care, not overhead. Better models, where incentives work for patients. We've talked defense. Now let's go on offense. Models where the money lines up with your outcomes. None are perfect, but each fixes a piece of the incentive map that drove your bill up. Start with independent physician associations and clinically integrated networks. These are groups of independent practices that band together for contracting, guidelines, and data sharing without becoming one company. Why this helps? They gain scale to negotiate and coordinate, but doctors keep local control. The thing most people miss is that good networks use shared quality bonuses and referral standards to reward prevention, not just procedures. Primary care, cardiology, and endocrinology agree on care paths, track outcomes, and split savings from avoided complications. You feel it as faster referrals, fewer duplicate tests, and more coordination, without the facility fee sprawl. Direct primary care is the simplest reset. You pay a monthly membership for unlimited primary care access, longer visits, same-day or next-day scheduling, text and telehealth, basic labs at cost. There's no fee-for-service treadmill inside that membership, which removes the pressure to churn visits or upcode. The limits are real. DPC is not insurance and doesn't cover hospitals, specialists, or big imaging. But paired with a high-deductible plan or a health-sharing alternative plus an HSA, it can shrink total spend while improving access. The quick win. If you're constantly stuck in 10-minute visits, a DPC clinic often restores time and follow-through that prevent ER trips later. Reference-based pricing tackles the price problem head-on. Instead of paying whatever a hospital bills, employers peg payment to a transparent benchmark like a multiple of Medicare. Providers can accept or appeal, but the anchor is public, not secret. When it's run well, with pre-service support, legal backup, and steerage to providers who agree up front, members get predictable prices and fewer facility fee shocks. The catch is communication. You need a navigation team that gets written agreements before care and steps in if a bill arrives above the reference. If you're at a company using this model, call the navigator before scheduling anything expensive and let them lock in the rate. Transparent bundled payments are another strong fit. One price covers surgeon, facility, anesthesia, implants, and post-op care for a defined episode. Hip replacement, colonoscopy, cataract, maternity bundles in some markets. Because the price is fixed, the team has a reason to avoid complications, repeat imaging, and prolonged stays. Employers often waive deductibles for these centers because the bundle is cheaper than the average piecemeal path. Your move: ask your plan for a list of bundled procedures and centers of excellence. If your needed service is on the list, you can save thousands and usually get concierge scheduling. Ambulatory surgical centers with site-neutral pricing are the practical middle ground for many procedures. Well-run ASCs publish global fees, or at least give firm all-in quotes, use efficient teams, and avoid the hospital overhead that triggers facility fees. Not every case belongs in an ASC. Complex patients and high-risk surgeries need hospitals, but cataracts, many orthopedic scopes, hernia repairs, GI endoscopy, and minor pain procedures often do. The play is simple. With CPT codes in hand, get an ASC quote and compare to hospital outpatient. If your surgeon only operates at the hospital, ask whether a partner uses the ASC and whether you can be scheduled there. Hospital at home is newer but promising. For selected conditions, pneumonia, heart failure, COPD exacerbations, systems can deliver hospital-level care at home with daily clinician visits, remote monitoring, and 24/7 response. When it's built right, you avoid hospital-acquired complications and the blizzard of facility charges. The model depends on solid logistics and payer alignment. Some insurers already cover it. If you or a family member qualifies, ask ER or inpatient teams whether a hospital at-home pathway exists, and what your out-of-pocket looks like compared with admission. Now, what do you do tomorrow? Map your high-value lane before you're sick. Identify an independent imaging center, an ASC that does your likely procedures, a DPC or extended primary care option, and a nearby urgent care with transparent pricing. Save their contacts. Ask your employer whether they offer bundles, centers of excellence, or reference-based pricing with navigation. If yes, get the phone number you call before anything elective. For specialists, favor groups tied into clinically integrated networks that publish quality metrics and accept bundled arrangements. Red flags are the ones refusing to quote, pushing hospital outpatient for routine procedures, or dodging questions about labs and reads. Green flags are written estimates, published package prices, and clear lists of billing entities. 2 phrases to use as you test models. Do you offer a cash bundle for this? And can you route this through your preferred partners with a single all-in quote? If the answer is yes, you've likely found a place where incentives lean your way. A quick microstory. A viewer needed a hernia repair. Hospital outpatient quote, a vague $18,000 to $35,000 range before insurance. An ASC bundled quote, $6,200 all in. Same surgeon. The employer waived his deductible for using the bundle. Total out of pocket, 0. He didn't game the system. He picked a model that rewards efficiency and outcomes instead of overhead. None of these models eliminate trade-offs. DPC requires a mindset shift. Bundles limit surgeon choice. Reference pricing needs a navigator. But each replaces per-click billing with clarity and aligned incentives. That's what you want. Care that pays teams to keep you well and charges predictable prices when you need procedures. The futures, 3 paths and what each means for you. Let's zoom out. There are 3 realistic paths from here, and your best moves change with each one. Whichever path wins, consolidation isn't theoretical. It's already in your mailbox. If your clinic's name changed, your bill will too unless you steer. Path 1, accelerated consolidation. Deals keep rolling, interest rates ease, and regulators struggle to keep pace. More practices join platforms, more clinics become provider-based, and facility fees spread into routine outpatient care. Prices drift up through allowed amounts, not headline charges, and your plan year quietly absorbs it with higher premiums and deductibles. What does that mean for you? Defense becomes standard operating procedure. You'll need to pre-flight every episode, confirm site of service, list every billing entity, and route labs, imaging, and reads to in-network partners. Build your personal care map now. Independent imaging, an ASC, a preferred urgent care, and hand it to your doctors. Push for all-in quotes for procedures and choose models that publish prices. If your employer offers bundles or centers of excellence, default to them. Think of it as structured shopping to neutralize consolidation's pricing power. Path 2, regulatory clampdown. Policymakers expand site-neutral payments and narrow or cap off-campus facility fees. Serial acquisitions face tougher antitrust scrutiny, with roll-ups required to report add-on deals and justify local concentration. Surprise billing arbitration gets unjammed and benchmarked more clearly. If that happens, the billing landscape simplifies. Price gaps by location shrink, and the temptation to migrate routine care into hospital outpatient settings fades. Your play shifts from aggressive defense to smart convenience. You'll still confirm entities, but you'll put more weight on quality, access, and continuity. In this world, leverage your plan steerage. If site-neutral rules level prices, choose the location with better outcomes and shorter wait times. Keep appealing obvious upcodes, but spend more of your energy on preventive care, chronic disease management, and staying in integrated networks that share data and track results. Path 3, employer-led disruption. Large self-funded employers get tired of year-over-year increases and build transparent networks with cash bundles, reference-based pricing, and navigation teams that steer employees to high-value centers. Some add direct contracts with health systems and specialist groups, plus on-site or near-site primary care with longer visits. Prices are posted, and members get shared savings when they pick efficient care. If your company goes this route, everything gets easier. Use the navigator for every elective service. Lock in written case rates before you schedule. Ask HR to add or expand bundles for your most likely procedures. If you're at a smaller employer, you can still copy the pattern. Ask your insurer for preferred sites, request all-in quotes from ASCs and imaging centers, and use HSA funds strategically alongside cash. Bundles that beat your deductible math. Now let's make it personal under each scenario. Under accelerated consolidation. Time your non-urgent care after contract renewals, not during them. Keep a running note with CPT codes for your common needs so you can comparison shop quickly. For chronic meds and infusions, ask about site of care shifts to office or home. If your clinic becomes provider-based, ask for a non-provider-based sister site or telehealth for follow-ups. And start using your insurer's price transparency tool. Even if clunky, it anchors negotiations when quotes and bills diverge. Under regulatory clampdown, ask your clinicians where site-neutral rules change their workflow. If the price is the same, press for the location that's safest and fastest. Reinvest the savings in care you've deferred, screenings, therapy, nutrition consults. Build continuity. Book your next follow-up before you leave and use portal summaries to cut down on repeat storytelling that wastes time and leads to duplicate tests. Under employer-led disruption, read the benefits guide. There's often a hidden phone number that unlocks bundles, second opinions, and waived deductibles. Call before you schedule anything expensive. If your plan uses reference-based pricing, get the pre-service agreement in writing and ask the navigator to confirm that all entities will honor it. If you're navigating for family, teach them the two key questions. Is there a bundle? And who bills me exactly? One more angle, your doctor's incentives. If you're in a consolidated market but want aligned care, look for clinicians in clinically integrated networks that accept value-based contracts or publish quality metrics. They're paid to keep you out of the hospital, not just keep the schedule full. Ask directly, how are you measured for quality? Doctors who can answer that clearly usually work in systems that reward prevention and coordination. The wild card is debt stress. If a platform hits covenant pressure, cost cuts and site shifts accelerate. You'll notice shorter visits, fewer staff, and more aggressive upsell. That's your cue to slow down and reroute to independent sites for anything elective. It's not about leaving your doctor. It's about moving the parts of your care most exposed to fees. If you remember nothing else about the futures, remember this. You can't control ownership, but you can control setting, timing, and transparency. Those three choices travel with you across all scenarios and cut your costs without skipping care. Ownership structure, not clinical need, now dictates too much of your bill, and the biggest swings come from site of service, out-of-network carve-outs, and stacked ancillaries, not your doctor's hands. Regulators, employers, and 90-plus advocacy groups are pushing back, but change is slow. Here's your single next step this week. Call your next appointment and ask 3 questions. What's the site of service? Will there be a facility or technical fee? And list every billing entity involved so you can confirm they're in-network and get CPT-coded estimates. If you want the insider view on how insurers set those allowed amounts and the exact scripts to get accurate pre-service quotes, watch the deep dive link next. Subscribe for practical, fact-checked money guides that protect your wallet from opaque healthcare pricing.